Hello and welcome. I'm Fernando, a GP in the UK. Today we're looking at the NICE guideline on renal stones, or NG118, focusing on what is relevant in primary care only. Without further ado, let's jump into it. And before we get started on the NICE guideline itself, let's have a quick overview of the clinical presentation. Patients with renal stones often present with severe colicky flank pain that can radiate to the groin and genitals, nausea and vomiting, which are common due to the intensity of the pain, lower urinary tract symptoms like urgency, frequency or dysuria, and hematuria, which can be visible or invisible. And if we suspect renal stones, we would normally check urinalysis to test not only for hematuria, but also for possible signs of infection like leukocytes and nitrites. So, when is immediate referral to the emergency department necessary? We should do just that if the patient has fever or signs of sepsis like tachycardia, hypertension or being systemically unwell, renal impairment or anuria, which would suggest obstruction, which is a urological emergency, and uncontrolled pain or vomiting, as these patients will need urgent care. On the other hand, we will consider non-urgent referral and investigations if we suspect renal stones because of milder but persistent symptoms or a previous history of recurrent stones. But now let's tackle a question: why does renal colic cause such severe colicky pain that radiates to the groin and genitals? There are three reasons. First, when a stone obstructs the ureter, it causes sudden distension and spasmodic contraction of the ureteric smooth muscle, which leads to that classic severe colicky pain. The pain can be a visceral pain from ureteric distension, which is poorly localized and felt deep in the flank and abdomen, or it could be a somatic pain when the stone irritates the bladder or urethra, leading to sharp, localized pain in the groin or perineum. And finally, the referred pain is due to the fact that the ureter shares sensory innervation with a T10 to L2 spinal segment, which also supply the flank, lower abdomen, groin and genitals. And here is one final clinical clue. If the pain starts in the flank, moves to the lower abdomen, and then radiates to the groin or genitals, it's a strong indicator of a stone migrating through the ureter. Now that we have reviewed the clinical presentation, let's start the review of the NICE guideline itself. In terms of diagnostic imaging, limited evidence shows that MRI, ultrasound and plain abdominal X-rays were not as good as non-contrast CT for detecting renal and ureteric stones. CT is more expensive than ultrasound or a plain abdominal X-ray, but the extra cost is likely to be outweighed by avoiding additional investigations when a first test misses the diagnosis. So, a low-dose non-contrast CT should be offered urgently, that is within 24 hours of presentation, to adults with suspected renal colic. However, for pregnant women and children, in order to minimize radiation, an urgent ultrasound scan should be offered instead. If there's still uncertainty about the diagnosis after ultrasound, for children and young people, a low-dose non-contrast CT scan can still be considered. Why do we need the imaging urgently, that is within 24 hours? Well, NICE says that the reason is because there are occasions where renal colic can cause renal function to decline quickly, so an early diagnosis is really important here. For pain management, we will offer a non-steroidal anti-inflammatory drug by any route as first-line treatment. This is because evidence shows that these drugs are the most effective compared with opioids, antispasmodics, and paracetamol. Most studies have used intravenous or intramuscular anti-inflammatories, whereas oral or rectal anti-inflammatories are more common in the UK. However, due to insufficient evidence supporting any specific route, NICE did not recommend a particular method of administration. If non-steroidal anti-inflammatory drugs are not enough or they are contraindicated, the next step would be paracetamol. Most of the evidence is based on intravenous paracetamol, commonly used in secondary care. However, even though NICE specifically recommends the intravenous route, in primary care we would normally use the oral route. We can consider opioids if both non-steroidal anti-inflammatory drugs and intravenous paracetamol are contraindicated or are not giving sufficient pain relief, but there are concerns about misuse and dependency. NICE advises against antispasmodics, as they offer no benefit over non-steroidal anti-inflammatory drugs. Additionally, in studies, they were administered intravenously, which increases the risk of adverse events and needs intensive monitoring. In terms of combination treatments, people with recurring stones may already self-manage with both oral paracetamol and non-steroidal anti-inflammatory drugs. There is some evidence showing benefit of a combination of non-steroidal anti-inflammatory drugs and oral paracetamol without an increase in adverse events. However, there was no strong evidence for any of the combination treatments, so they're not routinely recommended over the stepwise approach. In terms of metabolic testing, for adults we will measure serum calcium, and if it can be obtained, we will arrange stone analysis. However, children should be referred to a pediatric nephrologist or urologist for this assessment. In terms of preventing recurrence, we will give the following advice. Adults should drink 2.5 to 3 liters of water a day, and children and young people, depending on their age, 1 to 2 liters. They should add fresh lemon juice to drinking water. This is because lemon juice is rich in citrate, which can help prevent stone formation by binding to calcium and reducing calcium oxalate crystallization. It also alkalinizes the urine, making the environment less favorable for the formation of certain types of kidney stones, such as uric acid and cystine stones. And finally, by making water more palatable, it also encourages a higher fluid intake. We should also advise avoiding carbonated drinks. This is because many carbonated drinks, especially colas, contain phosphoric acid, which can lower the urine pH and promote the formation of calcium phosphate and uric acid stones. In addition, sugary sodas can increase urinary calcium excretion and decrease citrate levels, both of which also contribute to stone formation. We will also recommend reducing salt intake. This is because excess sodium increases calcium excretion in urine, which promotes calcium oxalate and calcium phosphate stone formation. Furthermore, a high salt intake can cause dehydration and a more concentrated urine, which can increase the risk further. And finally, we will not restrict dietary calcium, but recommend maintaining a normal calcium intake. And you could ask yourself, why maintain a normal calcium intake instead of restricting it? Well, contrary to what might seem logical, reducing calcium intake does not prevent renal stones and can actually increase the risk. The reason is that calcium from food binds with oxalate in the gut, preventing oxalate absorption into the bloodstream, reducing the risk of calcium oxalate stones, the most common type of stone. Additionally, inadequate calcium intake can lead to bone demineralization and an increased risk of osteoporosis. The actual management of renal stones corresponds to secondary care, and the treatments include both medical and surgical approaches, including shockwave lithotripsy. Examples of medical treatment include the use of alpha blockers, potassium citrate, and thiazides. And that is it, a review of the initial assessment and management of renal stones in primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching, and goodbye.